Welcome back to the Deep Dive. Today, we're really getting into something fundamental, nutrition during lactation.
It's a topic that's, well, incredibly elegant biologically, but often pretty misunderstood, isn't it?
Absolutely. And our source material is solid textbook-level stuff. Our goal here is to give you a real command of the whole picture, from the tiny cells involved right up to the big public health picture.
Right. We're talking mechanics, hormones, what human milk is actually made of, how dynamic it is.
And crucially, the support system is needed
Yeah.
because it's not just automatic.
Definitely not. And you really need that physiological foundation to understand how to optimize things for both the parent and the infant. Now, just a quick note on language before we dive in. We want to be inclusive. Terms like chest feeding or lactating persons are important and becoming more common, reflecting guidance from groups like the Academy of Breastfeeding Medicine.
Yeah, that's important context.
It is. But you'll find most of the established research we're drawing on still uses breastfeeding in mothers. So you'll hear us use a mix, trying to be accurate to the science while staying respectful.
Makes sense. Okay, let's jump right in then. Where do we start the actual milk-making machinery?
Yeah, the functional units. Let's talk alveoli.
Okay.
Think of them like tiny, tiny clusters, almost like microscopic bunches of grapes. They're lined with secretory cells.
So those cells are the actual factories.
Exactly. They synthesize and secrete everything. The fats, the lactose, the proteins, it all happens right there.
Wow. And how does the milk get out of those little clusters?
Good question. Around those secretory cells, you have these other cells called myoepithelial cells.
Okay.
They're like tiny muscle nets. When they get the right signal, a hormone signal, they contract.
And squeeze the milk out.
Precisely. Squeeze it out of the alveoli and push it down into the duct system, ready to go.
Like an internal pressure system.
Mm.
Got it. Okay, what about the timing? This whole process doesn't just switch on overnight, right?
Not at all. Mammary gland development, mammogenesis, starts way back in puberty and continues through pregnancy. But lactation itself, or lactogenesis, happens in stages.
Right.
Really, we talk about 3 key stages.
Right. Stage 1.
Lactogenesis thirst. This actually starts mid-pregnancy, maybe around 16 weeks, and goes through the first couple of days postpartum.
So milk production starts before the baby even arrives.
Kind of. The body starts making colostrum, that early milk. Protein and lactose levels are increasing, and importantly, the gaps between those secretory cells and the alveoli are quite large, sort of leaky.
Leaky, okay. And then comes lactogenesis 2.
This is the big one.
Which is the one everyone notices, yeah. Usually kicks in around day 2 to day 8 postpartum. This is when people say their milk is coming in.
What triggers that big shift?
It's mainly driven by the drop in the mother's progesterone levels after birth. That drop signals a big increase in blood flow to the breast tissue.
Uh-huh.
And here's the cool architectural part. Those leaky gaps, the tight junctions between the alveolar cells, they slam shut.
They seal up. Exactly. That sealing traps milk components inside the alveoli, the composition stabilizes, and boom, copious milk production starts.
Wow. So the hormone drop is the trigger, and the cells closing up is what allows the volume to build.
You got it. And then lactogenesis the third starts around day 9 or so. This is the maintenance phase. Supply gets established, composition is pretty stable, and it continues until weaning.
Okay, maintenance. That relies heavily on hormones, right? Prolactin and oxytocin. People mix these up sometimes.
They do. Let's clarify. Prolactin is basically the production manager. It tells the alveoli cells to actually make milk.
And what stimulates prolactin?
The main stimulus is the infant suckling at the breast. But here's a really practical point. Prolactin levels naturally peak during the night.
So that's why night feeding or pumping is so important for building supply.
Hugely important. It sends a stronger signal to keep production high.
Okay, so prolactin makes it. What does oxytocin do?
Oxytocin is the delivery driver. It's responsible for the milk ejection, the famous letdown reflex.
Right.
It causes those myoepithelial cells, the muscle nets we talked about, to contract and push the milk out.
And it's triggered by suckling, too.
Yes, primarily. But the letdown reflex is interesting. It's really sensitive. It can also be triggered just by hearing a baby cry, even someone else's baby.
Wow.
Or thinking about nursing, or sometimes sexual arousal. Many people feel it physically, like a tingling or sometimes even a sharp little pain as the milk lets down.
Fascinating.
Yeah.
Okay, so we have the factory running and the delivery system working. Let's talk about the product itself. Human milk. You said it's dynamic.
Incredibly dynamic. It's species-specific, meaning human milk is designed perfectly for human babies. and its composition changes constantly.
How so?
It changes over a single feeding, it changes throughout the day, and it changes as the infant gets older.
Let's start at the beginning then. Colostrum versus mature milk. Our source material had a great comparison, like table 6.3 visually shows.
Right. Colostrum, that first 1-3 days, is often thicker, maybe yellowish. Think of it as an immune booster shot.
High in specific things.
Very high in protein, especially secretory IgA and lactoferrin, key immune factors. Also higher in minerals like sodium, potassium chloride, and definitely vitamin A, which gives it that yellow color from beta-carotene. But it's actually lower in fat and carbohydrates than mature milk.
Interesting. So less energy, more protection initially.
Exactly. Then mature milk comes in. What's its main component?
Water, surprisingly.
Yes, mostly water, and it's isotonic with plasma. This is just brilliant design, meaning the concentration of solutes like salts is perfectly balanced with the baby's body fluids. Infants don't need extra water or other fluids even if it's hot out. The milk provides all the hydration they need.
Amazing. Okay, what about energy? Calories.
Mature milk provides roughly 0.65 to 0.75 kilocalories per milliliter, which works out to about 20.9 to 26.2 kilocal per ounce. And about half of those calories come from lipids, from fat.
And this is where that changing during a single feed thing comes in, right? The foremilk and hindmilk.
Exactly. This is super important. The fat content is lowest in the foremilk, the milk the baby gets at the very start of a feeding session.
Okay.
Then, as the feed progresses, the fat content steadily increases. The hind milk, the milk at the end of the feed, can have at least double the fat concentration.
Wow, double. So it's like watery, thirst-quenching stuff first, then the richer, high-calorie stuff.
Kind of, yeah. Think of it like cream rising to the top. The fattier milk needs more drawing out.
So if you switch breasts too early...
The baby might miss out on that high-calorie hind milk. That's why letting the baby finish the first breast before offering the second is often recommended, especially for ensuring good weight gain.
That makes so much sense. Does the mother's diet affect the fat?
It doesn't affect the amount of fat much or the cholesterol level, which is naturally high and important for brain development, by the way. But the mother's diet absolutely influences the types of fatty acids in the milk.
Like DHA.
Exactly. If a mother consumes more DHA, say from fish or supplements, her milk will have more DHA, which is critical for the baby's mission, for retinal development.
Got it. Okay, moving on to proteins. You said human milk is relatively low in protein compared to, say, cow's milk. Only 0.8 to 1.0%.
Right, which sounds low, but it's perfect for human infant growth needs. It provides everything they need without overloading their immature kidneys with excess nitrogen waste.
Ah, so it's efficient.
Extremely efficient. And the types of protein are important too. Casein forms a soft, easy-to-digest curd in the baby's stomach, unlike the harder curd from cow's milk. And whey proteins carry many of the immune factors, like lactoferrin and lysozyme.
Okay, and then carbohydrates. Our source text got really excited about these. Not just lactose, but human milk oligosaccharides, HMOs.
Oh, HMOs are incredible. Calling them just carbohydrates is like underselling them massively. There are over 200 different types identified.
And the baby doesn't even digest them for energy.
Nope. Their main job isn't feeding the baby directly. They function as prebiotics food for the beneficial bacteria in the baby's gut.
Okay.
And maybe even more importantly, they act as decoys. They mimic the receptors on the gut lining that pathogens try to bind to.
So the germs bind to the HMOs instead of the baby's gut wall.
Exactly. They get flushed out. It's a major part of the innate immune protection provided by human milk. Pretty amazing, right?
That's seriously clever biology. Sugars that act like bodyguards.
Mm.
Okay, briefly, minerals and vitamins.
Key thing with minerals is that the overall concentration is lower than in cow's milk, again, easier on the infant kidneys, but the minerals that are there are packaged for super high bioavailability.
Like zinc.
Yeah, zinc is a great example. About 49% of the zinc in human milk is absorbed, compared to only about 10% from cow's milk-based formula. Iron is similar, highly bioavailable.
And vitamins. We mentioned vitamin A and colostrum. Any concerns?
The main one is vitamin D. The amount in milk depends directly on the mother's vitamin D status. If the mother is deficient, the baby likely will be too.
Which is why supplementation is recommended.
Exactly. We'll touch on that later.
Okay, we've covered the how and the what. Let's get to the why. This section in our source material on the benefits, it was really compelling for both the parent and the child.
It really is. The benefits are profound. For the lactating parent, they start immediately postpartum. That oxytocin release doesn't just eject milk.
It helps the uterus shrink back.
Right. causes uterine contractions, which minimizes postpartum bleeding and helps the uterus involute return to its pre-pregnancy size much faster.
And longer-term benefits. We sometimes forget those.
We do. Lactation can delay the return of fertility, which helps with child spacing. And there's significant evidence for reduced lifetime risk of certain cancers, specifically breast, ovarian, and endometrial cancers.
Oh, wow.
Plus, lower risk later in life for things like rheumatoid arthritis, type 2 diabetes, and cardiovascular disease. It's quite protective.
That's huge. Now, for the infant, obviously nutrition is optimized.
Perfect balance, isosmotic, like we said, easy digestion, but the immunological benefits are just incredible.
Primarily that secretory IgA.
Yes, Sege is the star player. It coats the baby's gut and respiratory tract like a protective paint. It literally blocks pathogens from attaching and causing infection.
So fewer illnesses.
Significantly fewer acute illnesses. We see lower rates of diarrhea, ear infections, respiratory infections like pneumonia. It's well documented.
And the SIDS data was striking.
Yeah, a 60% reduction in the risk of sudden infant death syndrome for babies who receive any amount of human milk compared to none. That's a massive impact.
60%. Just wow. Any protection against chronic diseases later on?
Yes, research links breastfeeding to lower risks of developing conditions like celiac disease, type 1 and type 2 diabetes, and even some childhood leukemias.
And cognitive benefits, too.
There's an association with higher IQ scores, particularly noticeable in babies born prematurely or small for their gestational age.
Plus that analgesic effect you mentioned earlier, like a natural pain reliever.
It's fascinating. Studies show that letting an infant nurse during minor painful procedures, like a heel prick for a blood test, significantly reduces pain responses.
That's incredible. A parent can literally provide biological pain relief just by nursing. That's empowering.
It really is. And when you add up all these health benefits, the economic impact is huge, too.
Right, the 2010 study.
Estimated the U.S. could save something like $13 billion a year in healthcare costs if breastfeeding rates hit 90%. Mainly from preventing common childhood illnesses.
Okay, billions saved, lives protected. But let's get practical. The number one question or anxiety for many parents is, can I make enough milk? Let's talk supply and demand.
Absolutely the core principle. Milk synthesis, making milk, is driven by demand. The signal to make more milk is the removal of milk.
Simple as that. Empty the breast, make more milk.
Fundamentally, yes. Frequent and effective removal, whether by the baby feeding or by pumping, tells the body to keep up production. On average, a well-established supply is around 750 to 800 milliliters, or about 25-27 ounces per day by 4 to 5 months.
Okay, let's bust a myth. Does breast size determine milk production?
Nope, absolutely not. Breast size is mostly determined by the amount of fatty tissue, not the amount of milk-producing glandular tissue.
So size relates to?
Storage capacity. Think of it like having a smaller gas tank versus a larger one. Someone with smaller breasts might have less storage capacity, meaning they might need to feed or pump a bit more frequently to deliver the same total amount of milk over 24 hours as someone with larger storage capacity. But the potential production isn't dictated by size.
That's a crucial distinction. Frequency is the key then. So what are the practical signs parents should look for to know if the baby is getting enough, especially early on?
In those first few days, it's all about frequency. Aiming for 10 to 12 feeds in 24 hours helps establish supply. Latch is also key, making sure the baby takes a good mouthful of breast tissue, not just the nipple.
How do you know the latch is good?
Usually, the baby's nose is sort of in line with the nipple, mouth wide open like a yawn, then bring the baby quickly onto the breast. It shouldn't be persistently painful for the parent, and letting the baby finish one side helps ensure they get that richer hind milk.
Okay. And after the first few days, say by day 5-7, what are the output signs?
You want to see about 6 or more wet diapers per day, and typically 3 to 4 stools that are soft, yellowish, and maybe look a bit seedy.
And weight.
Weight gain is the ultimate sign, but initially some weight loss is normal. The key is that it shouldn't exceed 7% of the baby's birth weight in those first 5 days, and they should be back to birth weight by about 10-14 days.
Good benchmarks. What about pumping for parents who are separated, maybe going back to work?
To maintain supply when separated, you generally need to pump as often as the baby would feed, so maybe 8 to 12 times per day initially, mimicking that frequent removal signal.
Makes sense. Any impacts from things like breast surgery?
Yes, surgeries like breast reduction or augmentation can potentially impact milk production. Reduction might remove or damage ducts or nerves, while implants could compress ducts. It doesn't automatically mean someone can't breastfeed, but it requires careful monitoring of the baby's intake.
Good to know. Okay, shifting gears slightly to the parent's nutrition, we know it takes energy to make milk. How much extra?
The official estimate, the DRI, figures about 540 extra kilocalories per day needed for exclusive breastfeeding in the first 6 months.
Wow, that's like a whole extra meal.
It is, but the body is clever. It typically mobilizes about 140 kilocalories per day from the fat stores laid down during pregnancy to help meet that demand.
So the actual extra food intake needed is maybe closer to 400 kilocal.
Around 330, 400 kilocal, yes. The big takeaway, though, is not to restrict calories too much. A minimum intake of about 1,800 kilocal per day is recommended.
Can someone lose weight while breastfeeding?
Yes, modest weight loss is fine. A deficit of up to 500 kilocalories per day below total needs usually doesn't impact milk quality, but dipping below 1,500 kilocalories per day can potentially reduce milk volume.
Okay. And we said diet affects fatty acids and some vitamins. Does it change the protein or major minerals much?
Not really. The body works hard to keep the core composition of protein, carbohydrate, calcium, iron, etc. pretty stable in the milk, often drawing from the mother's own stores if her intake is low.
So the baby gets priority.
Absolutely. But again, some things are diet dependent, like vitamin B12. Vegans absolutely need a reliable source from fortified foods or supplements to ensure enough gets into the milk.
Right. And you mentioned a colic connection earlier.
Yeah, there's some evidence, particularly in the first 6 weeks, that if a breastfeeding parent avoids common allergens like cow's milk protein, eggs, nuts, wheat, soy, fish, it might reduce colic symptoms in their baby.
Mike?
Yeah, it's not guaranteed and it's not necessary for everyone. If colic is an issue, it might be worth trying an elimination diet under guidance, but it should be tested individually, not a blanket recommendation.
Got it. Okay, what about supplements for the baby?
All newborns get a vitamin K shot at birth to prevent bleeding issues. For exclusively breastfed infants, the big one is vitamin D.
Because not enough gets through the milk.
Exactly, unless the mother is taking very high doses herself. So standard recommendation is 400 IU of liquid vitamin D drops daily for the baby, starting in the first few days or weeks.
What about iron?
Healthy, full-term breastfed babies usually have enough iron stores for the first 4 to 6 months. Iron isn't typically needed until complementary foods, especially iron-rich ones, are introduced around 6 months. Preterm infants might need it earlier, though.
Okay, this brings us to the bigger picture support. Making breastfeeding work isn't just physiology, it requires a supportive environment, right?
Absolutely critical. Public health goals like Healthy People 2030 aiming for 42.4% exclusive breastfeeding at 6 months depend on it.
What are the biggest hurdles people face?
The main barriers consistently identified are lack of knowledge or confidence, poor social support from family or community, sometimes embarrassment about feeding in public, and major challenges related to employment and returning to work.
So what works? What kind of support helps?
Programs like the UNICEF Baby-Friendly Hospital Initiative make a difference by ensuring hospitals support immediate skin-to-skin, rooming in, and access to lactation help. Community support like WIC's Loving Support campaign is vital too.
And workplace support seems key for duration.
Non-negotiable. In the U.S., the PUMP for Nursing Mothers Act is a big step. It legally requires employers to provide reasonable break time and a private space that's not a bathroom for employees to pump milk for up to 1 year after their child's birth.
That legal protection is essential.
It really is. Systemic support has to be there to bridge the gap between physiological capability and real-world success.
Okay, fantastic overview. Let's try to pull the key threads together. What are the biggest takeaways from this deep dive?
I'd say, 1, the hormonal control is key. Prolactin makes it, oxytocin ejects it. 2, milk is incredibly dynamic, especially that foremilk, hindmilk fat difference.
Right, don't forget the hind milk.
Definitely. 3, supply equals demand. Milk removal is the signal. Breast size is about storage, not production limit. And finally, the benefits are huge, but success often hinges on support, personal, community, and workplace.
So what this really means for you, listening, is understanding that while the biology is amazing, successful lactation is often a learned skill. It relies on that physiology, yes, but just as much on the environment, the support, the policies around you. It's not just instinct.
Well said. And maybe a final thought to chew on, something interesting from the source material we didn't fully explore.
Okay.
We know that flavor compounds from the mother's diet, things like garlic, vanilla, mint, actually pass into the milk. Infants can taste them.
Really?
Yeah. So consider this. Could that early, repeated exposure to a variety of flavors through milk actually influence the baby's palate? Could make them more accepting of diverse solid foods later on, potentially reducing picky eating? It's like early flavor training,
Right.
programmed through the milk.
Pre-programming the palate. That's a fascinating idea, connecting lactation directly to longer-term eating habits.
Hmm.
Lots to think about it there. Thank you so much for guiding us through this incredibly detailed and important topic.
My pleasure. It's crucial information.
And thank you all for joining us for this deep dive. We'll catch you next time.